Assalamualaikum and a very good day. The topic that I'm going to present today is regarding non-depolarizing neuromuscular blocker. These are my presentation outline. I'm going to explain what is neuromuscular blocker, then non-depolarizing neuromuscular blocker, the mechanism of action, then the therapeutic use of this drug, and also the pharmacokinetics and the adverse drug effect, and my last slide will be the source of my findings. So basically, this drug block the cholinergic transmission between motor nerve ending and nicotinic receptor on neuromuscular junction. This drug is structural analog of acetylcholine. It acts either as antagonist, non-depolarizing type, or agonist, depolarizing type, but our main focus of this topic is non-depolarizing neuromuscular blockers. Now, what is non-depolarizing neuromuscular blockers? The first drug that was found to be capable of blocking the skeletal neuromuscular junction was curare, which native South American hunters of the Amazon's region used to paralyze prey. The drug tuberculin was ultimately purified and introduced into clinical practice in the early 1940s. Although tuberculin is considered to be prototype agent in this class, it has been largely replaced by other agents because of its adverse side effects. For information, this agent is no longer available in the United States. The neuromuscular blocking agents have significantly increased the safety of anesthesia because less anesthetic is required to produce muscle relaxation, allowing patients to recover quickly and completely after surgery. Now, I'm going to explain the mechanism of action of non-depolarizing neuromuscular blockers. In normal condition, acetylcholine will bind to the nicotinic receptor, thus will open the sodium ion channel. There's an influx of sodium ion into the neuromuscular junction. But as the patient given non-depolarizing neuromuscular blockers or NDB, NDB will bind to the nicotinic receptor, thus preventing acetylcholine to bind to the receptor. It will prevent the depolarization of muscle membrane, thus inhibit muscle contraction. As NDB is a competitive antagonist, so the process is reversible. Thus, we can reverse this action by increase the cholinesterase inhibitor. In high dose, NDB is capable to block the ion channel and further weakening the neuromuscular transmission. It will reduce the ability of cholinesterase inhibitor to reverse the action, and thus, when there's a complete blockade, no direct electrical transmission is seen. As for therapeutic use, these blockers are used therapeutically as adjuvant drugs in anesthesia during surgery to relax skeletal muscle. They are also used to facilitate intubation as well as orthopedic surgery, for example, fracture alignment and dislocation correction. As for pharmacokinetics, all neuromuscular blockers are injected intravenously because their absorption via orally is minimal. These agents possess 2 or more quaternary amine in their bulky ring structure, therefore making them orally ineffective. They penetrate the membrane poorly and they do not enter cells or cross blood-brain barrier. Most of the drugs is not metabolized and their actions are terminated by redistribution. Moving on to the adverse effect of NDB, non-depolarizing neuromuscular blockers. So basically, tuberculin can act on mast cell and further release the histamine. And this histamine can act with the lung, resulting bronchospasm. The release of histamine causes vasodilation, and this will lead to hypotension. In normal condition of ganglionic neuron, there's a nicotinic receptor on the post-ganglionic neuron. When the acetylcholine is released from the pre-ganglionic neuron, it will bind to the nicotinic receptor on the post-ganglionic neuron, and they will release the norepinephrine. Then this norepinephrine that being released by the post-ganglionic neuron will act on the target organ and produce physiological actions such as vasoconstriction. But in the presence of NDM or NDB, non-depolarizing neuromuscular blockers, this acetylcholine from pre-ganglionic neuron cannot bind to the nicotinic receptor, thus there's no norepinephrine will be released. It will decrease the blood pressure and thus will cause vasodilation too. This process will lead to hypotension. Now we already reached the end of my presentation. Basically, these are the sources that have been used. Thank you for your attention and I very much appreciate your time.